Good morning, respected faculty, my seniors and my juniors. Myself, Dr. Asha, Junior Resident, Department of Internal Medicine, going to present first case of today's clinical meet. Patient name Mrs. S, 48-year-old female from Sirsa, Haryana, homemaker, was admitted under GE2 unit on 21st of September to 21st of October with a presenting complaint of vomiting for 5 days. Background illness. The patient was apparently well till 24th of August when she felt pain in the epigastrium at around 2 p.m. while working at home. Epigastric pain was for 4 weeks ago. That was acute in onset, moderate to severe intensity, progressive. Visual analog score from 5 to 8 over 48 hours. That was continuous stabbing type, radiating to back, relieved with sitting up, unrelated to food intake. Pain was associated with shortness of breath, insidious in onset, gradually progressive, MMRC grade 2 to 4, no history of wheeze, orthopnea, PND, no history of decreased urine output, no history of abdominal distension, obstipation, where there was history of constipation present. History of presenting illness, vomiting for 5 days, insidious in onset, gradually progressive, initially 2 to 3 episodes per day, later progressed to 10 to 12 episodes per day, bilious, non-projectile. The vomiting was associated with constipation unrelated to food intake, not associated with abdominal pain, distension, obstipation, not associated with the blood. No history of fever, no history of decreased urine output. Personal history, the patient had mixed diet with appetite and sleep normal, bowel habit as constipation with the bladder normal, regular, no addiction. Menstrual and obstetric history was unremarkable. Family history was also unremarkable. On general physical examination, patient was oriented to time, place, and person. Pulse rate is under 10 beats per minute, regular, good volume, normal character, no vessel wall thickening, no radiofemoral delay. All peripheral pulses were felt. Blood pressure was 128/90 mm of Hg, right arm fine position. Respiratory, it was 22 breaths per minute. Thoraco-abdominal, SpO2 was 98% on room air, afebrile. No pallor, uterus cyanosis, clubbing, lymphadenopathy, pedal edema. Oral cavity has glossitis and dental caries. Fundus examination was normal. On systemic examination, abdomen has 3 into 5 centimeter tense palpable mass in the epigastrium that was smooth surface, tender, non-mobile, dull on percussion. The rest of the abdomen examination was normal. On systemic examination, respiratory, cardiovascular, and central nervous system examination was unremarkable. On investigation, patient had anemia with leukocytosis, which was resolved later on admission. In RFT and serum electrolyte, there is hyponatremia. Some hyponatremia with RFT is normal. In LFT, there is slight elevation of alkaline phosphorus with hypoalbuminemia. Patient had moderate hypercalcemia with low to normal phosphorus with high parathyroid hormone. On blood gas analysis, as we can see, there is a raised ICAL which was declining on the course of admission. Coagulogram was normal, and the sepsis workup was also negative. 24-hour urine calcium creatinine ratio was 0.08 on 26th of September. Daily ECG was done to monitor the QTC interval, where the QTC interval here, the QTC interval is 413, which was normal. And USG abdomen. Liver is 15 into 9 centimeter, grade 2 fatty liver, gallbladder distended with multiple gallbladder calculi, collection seen in the lesser sac. The impression was grade 2 fatty liver, cholelithiasis collection in the lesser sac. USG neck, there is 6 into 9 centimeter into 18 centimeter hypoechoic lesion at the inferior pole of the right lobe of the thyroid, query right parathyroid adenoma. Is the axial and the coronal section of the CECT abdomen of the patient was done on the 2nd of September. As we can see, there is necrotic collection in the pancreatic and extrapancreatic region with NJ in situ. I would like to invite Dr. Abhishek, nuclear medicine, to explain all these slides.
Good morning, everyone. So technetium 99M system EB for this patient was done. After the IV injection of technetium 99 system EB, 5 minutes anterior planar static image was taken, and another anterior planar static image was taken at 1 hour. At 5 minutes, we can see that there is physiological tracer uptake in the thyroid region, and there is one focal tracer uptake in the axillary region, which was axillary lymph node due to tracer extravasation during IV injection. At the 1 hour delayed image, we can see there is adequate washout from the thyroid glands with no focal tracer uptake in the neck or mediastinum except for axillary lymph node. On hybrid SPECT CT images, which was taken at 20 minutes, there was physiological tracer uptake in the thyroid gland, but no scan evidence of any abnormal focus to suggest parathyroid adenoma in the system EB scan. For F-choline PET for this patient was also done. This is MIP image. Here we can see a focal tracer uptake in the neck region and one axillary lymph node in the axilla. On the coronal images, we can see there is focal tracer uptake, which is 7 into 6 mm with SUV of 5.4. On the CT images in the coronal and axial and sagittal section, on the CT images, we cannot discern a separate nodule in the thyroid region, but there was tissue with nodule, which was given as likely right inferior parathyroid adenoma.
Thank you, sir. The course and management. Patient presented to OPD with a complaint of recurrent vomiting. Examination revealed the presence of epigastric lump, suspected to have gastric outlet obstruction due to collection. The patient was admitted and UGI endoscopy was done, which was normal, and was placed on there was on CCT abdomen, there was 13 into 7 into 4.3 into 7.9 centimeter collection, peripancreatic and lesser sac. That was extended to lesser sac. Patient was evaluated for the course of acute pancreatitis, which was found to have hypercalcemia. Fluid therapy was initiated and the patient was started on injection calcitonin. After starting the injection calcitonin, the patient calcium was 12.5, but there was no decrease in the calcium. Calcium on 9th of October was 20.4 milligram per deciliter. As the persistent hypercalcemia, hence the patient was started on zoledronate. After starting the injection zoledronate, the calcium was 12.4 to decline 9.4 milligram per deciliter. The unit's final diagnosis of the acute pancreatitis, query Galson's related parathyroid dependent hypercalcemia. Date of pain was 24th of August, 4th week of illness, moderate to severe disease, transient acute lung injury, acute necrotic collections, hypercalcemia related recurrent vomiting, de novo diabetes mellitus. I'll be discussing the following points. The cause of acute pancreatitis, as we all know, the main cause of acute pancreatitis is alcohol, followed by biliary. Other causes include the ERCP, iatrogenic drug infections, and metabolic causes include the hypercalcemia, hypertriglyceridemia, and there is less than 10% cause is idiopathic, which the cause is not known. Hypercalcemia-related pancreatitis most commonly seen with the primary hyperparathyroidism. If no obvious cause is present with elevated serum calcium, PHPT-induced pancreatitis should be suspected with the prevalence of 1 to 8%. How hypercalcemia causes pancreatitis? The raised calcium convert trypsinogen to trypsin with the increased permeability of pancreatic duct with deposition of calcium and phosphorus in the pancreatic duct. Direct toxic effect of the parathyroid on the pancreas cause pancreatitis. How to approach hyperparathyroidism? In parathyroid dependent hypercalcemia, we measure 24-hour urine calcium by creatinine ratio and 24-hour urinary calcium. If the 24-hour urinary calcium is If the 24-hour urine calcium is less than 100 milligram per day, and urinary calcium by creatinine ratio is less than 0.01, and the age is less than 40 years, and the strong family history, we suspect the familial hypocalcemic hypercalcemia because it is a autosomal dominant inheritance. If the 24-hour urine calcium is more than 100 milligram per 24 hour, and urinary calcium by creatinine ratio is more than 0.01, then three DDs is kept: primary hyperparathyroidism, tertiary hyperparathyroidism, and drug. In primary hyperparathyroidism, parathyroid adenoma or carcinoma. In tertiary hyperparathyroidism, there is history of underlying CKD, and in drugs there is lithium therapy. Types of hyperparathyroidism. Primary hyperparathyroidism has high parathyroid, high calcium, low phosphate, hypercalciuria, localization of adenoma on imaging like USG, system EB scan, and choline PET. In tertiary hyperparathyroidism, there is history of CKD on hemodialysis, high parathyroid, high calcium, variable phosphates with localization by the same. In lithium induced, there is history of drug intake, high parathyroid, high calcium, and low phosphate. This was the meta-analysis done in this September 2021, which there is 10 studies was included. 301 patients were used to compare the sensitivity of the choline PET over the system EB scan. As we can see, the sensitivity of the choline PET is 0.97, whereas the sensitivity is 0.5 for the technetium system EB. This was the another meta-analysis done. The 3 studies was included. The total population of 157 patients, choline PET was found to be a pooled sensitivity of 0.99 and pooled sensitivity of technetium system EB scan is 0.71. Why the choline PET is more sensitive than system EB scan? In parathyroid, there are 2 types of cells: oxyphilic cells and the chief cells. Oxyphilic cells has the abundant acidophilic cytoplasm with more number of mitochondria, whereas the chief cells has the big nucleus which secretes the parathyroid hormone. In system EB bind with the mitochondria, whereas the choline PET has the dual mechanism. One mechanism is choline bind with the mitochondria, and other is choline is connected to phosphocholine by the choline kinase. This is a calcium-dependent enzyme. This phosphocholine is bind to the membrane. So the dual mechanism of the choline PET represented the advantages of the choline PET over the system EB scan. This is the study done in our institute in September 2017, which comparison between the sensitivity, positive predictive value, and accuracy of the 3 modalities was done, which shows the FDG choline PET has 100% sensitivity, then the system EB scan has 80.7% sensitivity. Management of hypercalcemia. Corrected calcium is calculated with the above formula. In mild hypercalcemia, corrected calcium is less than 12 milligram per deciliter. Asymptomatic, mildly symptomatic, does not require immediate treatment. Adequate hydration to minimize the risk of nephrolithiasis. Treat the cause of hypercalcemia. In moderate hypercalcemia, the calcium level is 12 to 14 milligram per deciliter. With the asymptomatic or mildly symptomatic individuals may not require immediate therapy. Symptomatic changes in the sensorium require more aggressive therapy. Treat with saline, hydration, and bisphosphonate, which we'll discuss later. Severe hypercalcemia has the corrected calcium of more than 14 milligram per deciliter, require more aggressive treatment regardless the symptom. Restore intravascular volume, inhibiting the bone resorption via interference with the osteoclast function via denosumab and bisphosphonate. There are other treatment increasing the urinary calcium excretion, decreasing the intestinal calcium absorption. Treatment of severe hypercalcemia. The main aim is to maintain the adequate hydration. 2 to 4 liter of IV fluids is given to maintain the urine output of 100 to 150 ml per hour. In bisphosphonate, pamidronate and zoledronate is used with the onset of action is 48 hours. Lasts for 3 to 4 weeks. Denosumab has the onset of action is 7 to 10 days with the duration lasts for 3 to 4 weeks. The fast-acting drug calcitonin is used, where the onset is 4 to 6 hours, duration is till 3 days. Mechanism of denosumab and bisphosphonate. As the denosumab is a monoclonal antibody which inhibit the rank pathway by inhibiting binding of rank ligand with rank receptors. It impaired the osteoclast functions and the osteoclast apoptosis. FDA approved indication is the hypercalcemia malignancy and multiple myeloma with the adverse effect of atypical femoral fracture, osteonecrosis of jaw, and hypocalcemia infection. Bisphosphonate is also impaired the osteoclast function, osteoclast apoptosis, increase the osteoclast apoptosis with the side effect of GI intolerance and renal failure with the chronic side effect of atypical fracture and osteonecrosis of jaw. Management of primary hyperparathyroidism, medical management and surgical. In medical management, the management of hypercalcemia, the calcium mimetic calcium sensing receptor agonist is used in those the individuals with PHPT where the surgery is not done and where the surgery is high risk and the patient is contraindicated for surgery. Indication of surgery in the primary hyperparathyroidism, overt clinical manifestations of the disease, kidney stones or the nephrocalcinosis, fractures of the classic radiographic findings, classic neuromuscular disease, symptomatic or life-threatening hypercalcemia. Serum calcium more than 1 milligram per deciliter above the upper limit of normal. Creatinine clearance is less than 60 ml per minute. Presence of stones by radiograph. Presence of vertebral fracture. History of fragility fracture. Young age less than 50 years. Indication of hemodialysis in the renal failure, severe hypercalcemia with renal insufficiency and the heart failure, refractory to medical management with neurological manifestations. To summarize hypercalcemia management. In mild hypercalcemia, serum calcium is less to 10 to 12 milligram per deciliter, usually asymptomatic. Moderate hypercalcemia, the serum calcium is 12 to 14 milligram per deciliter. Asymptomatic is managed like a mild hypercalcemia, where the symptomatic IV fluids and bisphosphonate is given. In severe hypercalcemia, IV fluids, calcitonin, phosphonate is done. In recurrent and the very severe hypercalcemia, more than 18 milligram per deciliter, when hemodialysis is done, and PHPT patients are done thyroidectomy. Thank you.
Now I'd like to invite Dr. Padu, the senior resident on this case, for his comments.
Good morning, everyone. I would just like to give a brief summary. This patient has had acute pancreatitis, which was of moderate severity. She was initially treated at the outside hospital, and during her initial evaluation, she was found to be gallstone. She was found to be having gallstones, and the pancreatitis was attributed to gallstones. And later, she had presented to our OPD with the complaints of recurrent vomitings. We thought it might be gastric outlet obstruction due to acute necrotic collection, and we have done an upper GI endoscopy and then CT scan. Upper GI endoscopy was essentially normal. CT scan, although it showed collection, it did not show any evidence of compression, and during her admission on evaluation, the patient was found to have hypercalcemia. The thing with hypercalcemia is hypercalcemia can cause both acute and chronic pancreatitis. For chronic pancreatitis, we have data from our center. It was published by our department and Department of Endocrinology. A total of 59 patients with primary hyperparathyroidism and chronic pancreatitis. They have found out that in patients with chronic pancreatitis, almost the prevalence of primary hyperparathyroidism was 18%. And it is also known that through case control studies, which was published from Japan, around 800 patients, that the prevalence of primary hyperparathyroidism was greater in the patients with gallstones. It might be because of reduced GB motility, because of calcium-related reduced neuromuscular excitability. However, they did not define the exact mechanism why gallstones are increased in patients with hyperparathyroidism. And second, when coming to acute pancreatitis, hypercalcemia can cause through various mechanisms, as mentioned by Dr. Asha. And in this case, we have evaluated for hypercalcemia. Initially, we found a nodule on ultrasound, but it turned out to be negative on system AB. So through consultation from Department of Endocrinology, we went ahead with the choline PET, where we have found evidence and later was managed on the basis of it. Thank you.